So, hello and good evening to everybody around the world. I'm Alexander Mamigani, and today's topic is more than exciting. It's something really new. Dr. Clemens Weber, who is a well-known Norwegian neurosurgeon, will tell us about cervical spine fixation, not open but minimal invasive procedures. Dr. Weber is pretty known from recent studies from the Nordston study group regarding the treatment of degen spondy fusion versus decompression only. We all know his work. He co-authored in the New England Journal of Medicine. He's an academic spine surgeon, a neurosurgeon with a passion in spine. He has performed a PhD in Norway, and the topic was spinal imaging. And thank you very much that you have followed my invitation, Dr. Weber. We are more than excited to have you as our guest here on the tonight's session. Can you please tell us whether there will be a paradigm shift in cervical spine fixation, or will we forever stuck in open procedures in the C-spine, whereas we can do a lot of MIS surgeries in the TL junction, in the TL region? Dr. Weber, I'm happy you're here. It's midnight in Norway, and thank you. And I would love to hear you starting your presentation.
Dear Alex, thank you very much for the kind introduction. I hope everyone can hear me now. Yes, Alex asked me a few weeks ago if I could talk about this topic. We exchanged some messages a few months ago on these percutaneous or mini open pedicle screw placement in the cervical spine. And I'm very happy to be here today to introduce or just to present our workflow for these screws. And I think we just get started now. So let's see. Conflict of interests. I had some presentations and did some consulting for BrainLab, which was less than 2,000 euros last year. And besides that, there are no other conflicts of interest regarding this presentation. I think we can just start with a case. I think you all like cases, and this is one of the first patients that we treated with this kind of technique. Was a 77-year-old male. He has known hypertension, ASA2, and he was out in the evening and had a glass of wine and maybe some aquavit, and felt from his own height, had a low energy fall, and complained about neck pain immediately. He was initially described as paraplegic, but in the ER, he didn't present with any neurological deficits. So the workup, CT scanning, of course, showed this injury. I think you all can see that there's an underlying condition in this spine. It's not a normal spine. It's an ankylosed spine. And we all know that these fractures are usually very unstable. They go through the whole spine. It's like a long bone fracture. It's not a flexible fracture or injury. And we have some data from our colleagues in Oslo on these AS fractures. The numbers in Norway are actually decreasing. It's interesting. But most of these patients usually get treated surgically, as these fractures are highly unstable. And we can see that they still have a high mortality. So, of course, the question in this case, Alex, what would you do Maybe you can just give your comment. If you have a fracture like that, would you go for conservative? I don't think so. But if you go for surgery, what would you do? What kind of surgery would you do in this case?
Clemens, if you please stay on this slide, this is very interesting because my personal impression is the complete different, the opposite. I think that the ankylosed spine numbers and fractures is increasing. Maybe it's a little bit more dish than the inflammatory ankylosing spondylitis type, but I see an increase. So very easy. For me, these fractures are classified as B3 according to AO spine. There can only be one more severe injury from the morphology. This would be a C type. And I've seen some patients with a missed diagnosis ending up in a C situation, in a dislocation, or they develop a slow myelopathy due to intraspinal extradural hematoma, which can compress a lot. And so early management is, in my experience, and I guess it's a worldwide accepted algorithm to not lose time to not in emergency, not within 6 hours, but when the patient has no neurology, to have a definite stabilization within 48 hours. And I'm posterior only. In these kind of cases, I would only do a posterior stabilization.
What kind of posterior stabilization? So if we go back to the images, this is C6, 2, 3, 4, 5, 6.
So
Open
it's
surgery.
for me,
What?
it's yeah, for me, it's open midline surgery, exposing the spine, I guess, from C2-3 down to T2. And it's like a minimum 2 up, 2 down, but maybe I will do 3 up, 3 down, have long lever arms to really have a strong stabilization. I would do double rod. I wouldn't do a cross connector, but on each and every side, 6 screws will be perfect. So pedicle screws in the upper thoracic and massa lateralis in the subaxial C-spine. I'm a Margal pupil, so my teachers have worked with Margal, so it's a massa lateralis screw Margal type for me.
Okay. So we all know that these are, it's a large approach. We need to cut the muscles. We need to open up wide. So what would be the estimated blood loss in a case like this? A liter, 1.5?
Uh, it is
Even
a
more?
question of being honesty. No, I think it's less than 1 liter. But if you
Okay.
start in your career, you end up approximately 1 liter, like 1000 milliliters EBL.
Yeah.
But with time you're improving. I think we don't have these kind of muscles in an ankylosed spine because the muscles often is atrophic, and with atrophy the blood, the perfusion gets down a little bit, but nevertheless posterior cervical crossing the junction is more red than we all want to have this.
So in my experience, this would be a liter of blood loss in a case like that if you go for 12 screws. Another problem with these patients, as you already mentioned, is that they have poor musculature and they're very frail usually. They get problems later on when you detach all the muscles and it doesn't grow really good, and they get more atrophic muscles and above the screws. The screw heads can penetrate through the skin and so on. So I think the open approach for a case like this can be yeah, attached to some complications. So we already mentioned lateral mass screws. I think in most cases, or many surgeons still use lateral mass screws, and they are easy to place, and that it's a good option, definitely. But we know that they are not as stable as pedicle screws, and so even if you place 6 screws above the fracture, maybe 1 or 2 are not optimally placed, and sometimes you get a lateral breach in the lateral mass, and bone quality can be poor in this area. So we know already from research, this study is from 2006, that cervical pedicle screws are 4 times stronger with regards to the pull-out strength than lateral mass screws. So we discussed this earlier, and you say open approach, lateral mass screws combined with pedicle screws. We often use anatomic landmarks. You mentioned Margal already. You can use a C-arm as well to check your crew positioning. Next level would be to use navigation in a case like this, and also with an open approach. You can do surface matching, and you can safely put pedicle screws with that method. You can also combine your approach. You can do an open approach. Sometimes it can be very difficult if you want to put pedicle screws. I will talk about that later. Because of the angulation, and then you can do step incisions and put the screws through the skin, through the muscle, but still have control from the inside with an open approach. You can do that navigated also with surface matching or with intraoperative CT scan image guidance. Or the next option would be to do it mini open or percutaneous. We all do that in the thoracolumbar spine for fractures, injuries, unstable situations. I think it's quite common around the world now to use percutaneous pedicle screws in the thoracolumbar spine. And why shouldn't we do that in the cervical spine? I think many surgeons are a little bit afraid, and I think that's very good to be afraid. But if you have systems that make this more safe, you can at least try to find out if there are other options that might be better for the patient. So about the screws, cervical pedicle screws, the angulation, as I mentioned, can be difficult. When we are in the upper lumbar spine, we usually go straight ahead with our pedicle screws. L5 as one can be more demanding. But if we come to lateral to pedicle screws on the cervical spine, as you can see on these drawings here, the angulations can be up to 60 degrees. And the next problem, there are very important structures around and in between. So we have the spinal cord in the middle. We have the vertebral arteries, and especially in the upper cervical levels. And it's a very small path that we can use here to put a screw through the pedicle into the vertebral body. So I already mentioned this in a way earlier. If we go percutaneous, we don't have that much muscle trauma. We don't have to detach all the muscles from the spinous process and from the lamina. Another problem with an open approach, especially in pedicle screws, if you have this angulation of like 45 degrees, you always get in conflict with the retractors, with the muscles, with the skin. You get pushed medially, and that can be difficult to place a good pedicle screw here. That's actually an advantage with the transmuscular approach, with the percutaneous or mini open approach, that you don't get this pushing effect from the sides to your instruments. In our center now, we use navigation for all of these cases, obviously, and we plan these screws before in these type of injuries. We look at the angulation on the slices, on the CT slices, and we also do CT 3D reconstructions to look into the optimal positioning with and planning of the screws. There have been done some studies on these cervical pedicle screws that can be placed minimal invasive. This is one of the earlier reports on some cadavers. I think they used 4 cadavers, and then tried in 6 patient cases where they put these screws minimally invasive, and described this as safe and effective, and with minimal injury to the paraspinal muscles. There's another group. I think these 2 studies are on the same cohort of 27 patients. And they also describe intraoperative navigation guidance and a minimal invasive screw placement in the cervical spine. There were no nerve root injuries, spinal cord injuries, or vertebral artery injuries in these cases. This is probably the largest study until now, with 67 patients, where they even described the technique and found an abbreviation for it, minimal MICEPS. They call it MICEPS, minimal invasive cervical pedicle screw. MICEPS sounds really good. And they also say it's a safe and effective approach. So our system, we use our setup, our workflow, we use intraoperative image guidance with a cone beam CT scan. Cone beam CT, I don't know if that's known for everyone, it's less radiation than a regular CT scan. I think it really comes from dentistry. I think that's where they started with these cone beam imaging. And so it's supposed to be 10% of a regular CT. Might be a little bit more if you do. It depends on how much radiation you have to use, if it's a larger patient, and so on. So this is what we do, and I stole this from one of the AO Spine papers on safety and efficiency in navigation. So where we have different options. So with the dark blue, I think that's what we all are used to in the thoracolumbar spine, that we use in C-arm and do a 2D freehand technique. So this can be advanced with the cone beam CT, with 3D imaging. We can do that with intraoperative imaging or fluoroscopy based. And we can do that also with surface matching, but then we have to do open surgery again. We can do it freehand, robotic, and I think one of the next options will be augmented reality. I will come to that later as well. So we use the system. The patient will be placed in prone position on a carbon table with a carbon Mayfield. We make a small incision over one of the spinous processes to put the reference frame. Then we do perform a 3D scan and plan our incisions accordingly. It's very important when you do the scan, I think you can see it on the screen here, that you include the skin on the scan, not only the spine. So we always include the skin just to know where we have to put our incisions, because in this case it can be pretty far lateral, and it's very important to see where you have to go in. And yeah, this is the
may I
patient.
ask you, Clemens?
Of course.
Sorry to to interrupt you, but the image before, the slide before, do you drape differently in percutaneous cervical spine, or do you drape, have one standard of draping to the sterile field? Is this standard, or is this a wider draping?
It's a wider draping, of course. We usually go, almost halfway on the lateral side of the neck. As we learned it from the first case, the incisions can be quite lateral. So that's a good point. And we have the patient in the, we have like a small or a large sac over the patient to collect all the sterile draping also under the patient so that we can do the 3D spin. But that's the same for all other cases as well. So this is the patient with the images we saw earlier. So here we performed a mini open approach with parasagittal incisions, as you can see on the images. And we've been very careful in the beginning to put or to drill with the drill guide, with the navigated drill guide, and put the K-wires first. Sometimes we use this navigator operator concept that one surgeon is drilling, the other is holding the drill guide and is concentrating on the screen, checking with the drill guide all the time, and the other surgeon is drilling and just feels with the drill and has the anatomical control and the haptic feedback with the drill. We don't have a robotic guidance system, and we haven't used it. I have no experience with that. But in a case like this, I would really like to have the haptic feedback because the vertebral body can rotate if you push too hard. And I think it's very helpful to have the manual control here. So in this case,
Clemens,
yes, Alex.
Clemens, may I ask you? So,
Yeah.
the first case, you were not aiming for adding fluoroscopic control. You were, from the start, relying 100% on navigation.
Yes.
And the
But
same
I
you
will.
do in thoracic or lumbar? Do you have the experience from thoracic and lumbar surgeries so that you rely 100% on? Because I know there in the beginnings, when you start with navigation, um, sometimes during the first surgeries, you lose faith in the system, and then you, come on, let's have a look with the C-arm. So it's always a little bit trust in the setup.
Yeah, I know what you mean, and we had some issues in the beginning. But we've done I don't know how many cases now, 150, 200 cases with this intraoperative CT guidance, and altogether, all the thoracolumbar, and we haven't had any major revisions or problems or screw displacements. It's for us, it works very, very good. But you can see here, that's why I put up this image. We were really careful here. So we after we put the K-wires, we did X-ray control and a 3D scan as well, because I think this was the second case, and you see on the X-ray imaging, it's a poor image quality, and you see also the K-wires in the upper levels. They are not really in the vertebral body. We were really careful, and that in this case we performed also a 3D scan after we put the K-wires and before we went on with tapping and screws. And that's the next step here in this surgery. We actually used the thoracolumbar system here, as you can see. It's not a cervical system, and we used the cannulated screws and put in the rods. And we also, before we put the rods, in this case, after placing the screws, we did a control scan. You see the imaging here on X-ray. You cannot be 100% sure that everything is good. But then we can do a 3D scan, and we can see that the screws are placed in the pedicles. On the left side, you can see the left screw. It's slightly touching the spinal canal. We are when we are drilling, we are more afraid of hitting the vertebral artery than the spinal cord. The vertebral artery will be close to the bone, so the artery is very close to the bone here, whereas the spinal cord usually is a few millimeters away. So if you have this the space of like 5-6 millimeters here, maybe 4, you can you can still add 2 millimeters here on the side, but out here there's usually no extra space. So I think that's one of the major issues here, that the risk of the vertebral artery injury is much higher than the spinal cord injury. So this was the 3-month.
Can you?
Yeah.
Sorry that because
No problem.
these images are amazing.
Yeah.
These are amazing. Can you go one slide back where we can see the sleeves of the system? Because in ankylosing spine, or one more slide back where we can see it on the photo. When we have an ankylosed spine, a rod insertion is a crucial part. If you don't align the screws smoothly, if you have a step or a gap and you put in the rods, you can easily have a worsening, a translocation or dislocation of the fracture zone. Are you happy on the C-spine with the sleeves and the alignment? My first thoughts have been, oh, the thoracic one, the lowermost instrument vertebra, the screws are a little bit not in the same alignment like the cervical ones. Can you see there is a danger, or because you cannot control it with your eyes? So here, the lowermost instrumented vertebra looks like 5 millimeters different to the C-spine ones.
Yeah, it's a very good point. In this case, we actually advanced the screw after the spin. I think it was only on one side. The other side was good, and you can see it here. There you have a very nice alignment, but here there's a step, and we usually plan these screws before, so that we have the trajectories planned and we try to follow them. Which is not always that easy, but it works quite well. And if you remember the CT scan, this fracture was not displaced at all in the beginning. I think it was a very pint AS fracture with no dislocation. So I think that was also a factor that made us more or gave us a more safer feeling for this type of surgery. Okay, let's go on. We have this one. This is 3 months later. I think one of the screws actually perforated the vertebral barrier anteriorly. But anyway, this fused. The patient is happy. He has there's no more complaints. There's no neck pain. There was no atrophy of the muscles. We had no wound problems with this guy, and he's walking around and happy. But the next step from mini open to even less invasive or minimal invasive can be percutaneous. This is a patient, I think I forgot the X-ray or the CT, yeah, with a C3, C4 injury. Same setup with the prone position in Mayfield and the reference frame. You can see the incision for the reference frame is actually longer than for the two screws here. It's also pretty far lateral on the side. You mentioned the draping. Here we get in conflict already. I think this was our very first case. And so same thing, we actually used the Piccolini retractor here just to see a little bit more of the area. And again, a navigated drill guide and K-wire placement. This is the case. This is the intraoperative scan. You still see the blades. This is a system with short blades. I think they're 2.5 centimeters. And this is what I mentioned. If you push too hard here with your drill guide, or you push the vertebral body away from yourself, you get a rotation that way, and you have a higher risk of hitting the vertebral artery. So therefore, very careful drilling, always with a haptic feedback, and to feel how the drill advances into the bone. I think that is very, very important to avoid any catastrophes here. So here as well, cannulated pedicle screws placed over the guide wires, and you see small incisions. Here we didn't have any problems with the muscles. It was a very, very skinny person with a yeah, not a large neck that we sometimes see. So no problems with the rod placement here. And these are just to compare the CT, the intraoperative and the postoperative CT. I think this was the first case, and we wanted to document it with the postoperative CT as well. But now in most cases we just do the intraoperative CT control, and when we are happy with that, we don't do any more CT control the day after. So you can see how close we are to the vertebral artery on the left picture on the right side. But also here we didn't have any problems with this case. Another patient, 42-year-old male. Of course, we are in Norway, cross-country skiing accident. He complained of neck pain immediately, and also radicular pain, the C6 dermatome, and some numbness on his thumb, but no other neurological deficits. These are some of the images. I think we can classify this as a C fracture, a C-type injury with a translation, and a disc rupture and fragment intraspinal. So what we did here, first anterior with a cage and a plate, and then we supported with screws from posterior, and you see the scars 3 months after surgery. One from the in the midline from the reference frame and for the screws. And this patient was also very happy after surgery. And yeah, one of the problems is that we.
Clemens,
Yes.
may I ask you, do you notice from the outcome you said it's happy after surgery, do you notice a big difference to open procedures in the early days after surgery?
I will show you later. I will come
Okay,
to that.
sorry.
Yeah,
Sorry.
I'll show you some numbers as well. So what is one of the major issues for us is that we don't have a dedicated system, or there's no distributor in Norway with a dedicated cervical MIS system. There are a few systems on the market already. I don't want to mention any names. There's also a big provider from a big company from Central Europe, but they consider the Scandinavian market for too small, so they don't sell the system here. That's very annoying for us, but that's how it is. But there are different systems already around with taps or with cannulated screw systems with blades. So there are systems for this type of surgery already. Alex also asked me to show you some of our new advancements now, and I'm sorry I don't have any recordings from any cervical spine surgery, but I wanted to show you some of these mixed reality videos that we use in our navigation setup. And we had these AR glasses on loan last year, and we're planning to buy them on a permanent basis, and we also want to try them on the cervical spine. So this is how you can plan the screws, and this is what you see as a surgeon, and the assistant is seeing exactly the same. You have to remember this is a recording from the glasses, and that's why there's a mismatch of the reference frame, because it's not on your eye. And this is how you place the screws with these glasses on, and you have the images right in front of you. You don't need to turn around to your screen anymore, and it can really help to place your screws safely and in a very good ergonomic position for the surgeon and the assistant as well. So there you can also use 3D models here that you can move around and play with and so on. I'm not sure if that is so necessary, but yeah. When you've done your intraoperative implant control with a 3D scan, you can check that immediately with a pointer. You can see your screw placement while your assistant is closing up. So it's a very effective system. This is not a cervical case. This is a TLIF. You see the poor cage position there, but yeah. So you asked about some more information about the postoperative course of these patients and how do they perform. And we actually started a pre-post comparative study. It's part of our internal quality assurance, and we looked up some patients that we did right before. And after we introduced this kind of approach, and we have done 7 MIS cases now, and we compared them to the 7 cases with open surgery before. These are all fractures that didn't need any decompression. These are only cases where we need to stabilize an injury, which was unstable and with no need to decompress anything. So yeah, pretty similar patient cohorts. In the open approach, we had a few more spinal cord injuries, and that also reflects the length of stay. But if you see here, if we go from lateral mass screws to pedicle screws, we can use less screws. This is one of our first experience. We do shorter constructs. We instrument less vertebra because we trust more in the pedicle screws, and we consider them to give us stronger constructs. And as you mentioned with the AS spine, you would put say 6 lateral mass screws. We put 4 pedicle screws, and I think it's stable enough. And I think one of the major or one of the most interesting points here is the blood loss. And we looked that up. So a liter is not very unusual. In short constructs, it can be less. In larger constructs, it can be more. But if we look into these 7 cases with MIS approach, we can reduce that to 160 milliliters per case. And we also looked up or calculated the blood loss per screw, which was reduced significantly. We haven't had any misplaced screws or reoperations in these cases. I think our colleagues, yeah, I said that before. This is from our colleagues in Freiburg in Germany. They published 6 patients now with excellent and good screw positions in over 80% of the cases without any neurovascular complications. And this is similar to our experience as well. We will follow up our patients and we collect more data on future cases as well. And I will probably tell you more about that later. So our initial experience is that we can do more stable constructs with fewer screws when we use pedicle screws instead of lateral mass screws. And it's less invasive than an anterior approach. In some cases, we just go only anterior instead of do any combined approaches. So we eliminate all the complications that we can have from anterior surgery. And with navigation and intraoperative 3D scans or CTs, we can have very accurate screw placement. We can do intraoperative control, and we will reduce blood loss and it's less pain. Length of stay can be reduced, and I think this skiing accident patient, he had like 5 milligrams of oxycodone the evening after surgery, and the next morning he left the hospital. So in our experience, this is a feasible alternative to open surgery. Our major problem still is that we don't have a dedicated system with long taps in Norway, only with short taps. And we hope that we will get something like that soon. So we are moving to a new hospital now in November. These are some images from our new OR that we will get there. Oh no, sorry. This is the hospital. So I would thank you very much for listening. And I also want to thank all my colleagues, especially David Werner and Kjell Akre and Masia Bepahani, that are all involved in these kind of surgeries. We have a really good team with all the nurses and the OR staff and anesthesia around that helps us to perform these surgeries. And yeah, I would like to thank you for listening and inviting me for tonight, Alex. If there are any questions, I'm very happy to answer them.
Oh, thank you very much, Clemens. This was an awesome talk. It's a little bit a look into the future. Actually, I don't know how many screws I have placed in the C-spine, but I've never seen images like these before, and it's very impressive. Clemens, when you go back to one slide before with the take-home messages, or 2 slides or 3 slides, I want to ask you, I got these messages, but what kind of setup, what does it need to do cervical percutaneous screws? So it's navigation. Is there an alternative to navigation? Do you imagine that anybody managed this with fluoroscopy alone? Or is this the need 100% to be a master in navigation?
We have discussed this before with other colleagues, and I think if you want to be on the safe side, you should use navigation and some kind of image guidance to do these type of approaches. If you go percutaneously or even mini open, you don't have these anatomic landmarks like you have with open surgery. If you have a patient with very large pedicles in the lower cervical spine, I think it can be saved only with a C-arm, and we have done that before as well. I think many surgeons have done that with, for example, C7 pedicle screws with a C arm. But if you come to C6, C5, C4, when you have like 4 millimeter pedicles, that can be very demanding only with a C arm. I'm not really, and then you get the problem with the vertebral artery above C6 as well. So that can be very dangerous. I think maybe in very few selected patients with large pedicles and high exiting vertebral artery, but in yeah, I'm not sure. I wouldn't try. I'm not that experienced.
Yeah, my gut feeling says I will do it all navigated. Another question is neuromonitoring adding more safety, or is neuromonitoring not really adding safety to this procedure?
So most of these cases with fractures that don't need any decompression and without any neurological deficits or with a complete injury, like in Asia A or in Asia E, we don't use. No, I don't really see that it adds that much. And in incomplete cases where you have to go in very fast, you don't want to use that much time, and we don't have any option to do that in the evening with neuromonitoring or even at night. I think I'm not sure if it adds that much. I know in other countries it might be legal reasons for that, but I'm not sure. Are you using neuromonitoring in trauma cases?
No, we don't. Actually, I would love to have a neuromonitoring 24/7, but in the night, when it comes to emergency decompression, I think the surgical decompression is doing the job.
Mm.
And I've never missed IOM. Completely different to intradural pathologies, but in a trauma setting, not elective, yes, but not in a trauma setting. Um,
I think it's different, as you said, for intradural cases and tumors, and for deformity surgery with large corrections. But in these cases here, I don't really see the big advantage.
My next question is, what about the upper cervical atlas C1, C2? Do you go for these anatomical
Mm,
region as well, or do you first stay in the subaxial C-spine?
mm. Not yet. We haven't done that yet, and I'm not sure if that is feasible. I think if, for example, a transarticular screw, that would be possible for C1, C2, but C1 screws percutaneously, I'm not sure. And yeah, we've discussed that also with us, with other colleagues from Germany, and I don't know if anyone has done that before. I think in one of these papers, it was actually described um, that they also used it for C1, C2 instability. Oh, no, serious talking back here. Let's see, I think here they said indications for surgery included type 2 odontoid fractures.
Yeah,
So,
C1 to C7, yeah. Oh, this is
yeah,
especially C1 can rotate a lot if you
yeah,
press a little bit too hard.
yeah. It's a very
Clemens,
mobile ring. Yeah.
my last question is maybe the impossible to answer, but where will be where will we be in 5 to 10 years? What do you guess? Will you switch a certain amount to MIS in the C-spine, or is this too challenging to say that this has the potential to be a standard procedure in the C-spine, like it is standard in the thoracic or lumbar spine to do is
Hmm.
MIS?
So we are a small center. We are Stavanger University Hospital is a small hospital. We don't have these large amounts of patients like others. We live in a country with a with very few other people around us, and we don't have this experience with hundreds and thousands of cases. For us, the introduction of navigation with intraoperative CT has led to kind of democratization of spine surgery. We can do much more and much safer with this systems, and I think with further development of intraoperative or less invasive approaches and implants, especially in cases where you don't need any decompression or and you have the possibility to use a navigation system. I think in the future more and more surgeons will switch to MIS. I think we had the same discussion 15 years ago when we all started with percutaneous pedicle screws in the thoracolumbar spine. And I think you and I, we are both trained with open surgery in the beginning, and then we switched to the percutaneous systems. And I think this is also feasible in the cervical spine. Not in every case, definitely not. And especially in cases where you have very small pedicles or very mobile spines, it can be very demanding. Sometimes you have to do 2 navigation setups, one above the fracture, and then you do a new spin to you put your reference frame below the fracture, then you do a new spin and navigate the screws below the fracture, so that you can reduce the inaccuracy of the fracture. But I think in more and more surgeons are talking about this now, and I think we will see it more and more in the future. And so far, there are not that many papers out there, but most of them say it's quite safe. And I think if you do that with open surgery and surface matching, and you still have all the retractors in your way and the muscles are pushing, that can be even more risky.
Yeah, I see this point very important, that retractors and the tissue, the annoying tissue that can lower accuracy a lot without the surgeon knows it and he doesn't see it. These false directions, this misplacement of the screws, it needs a lot of experience, and pure MIS, pure transmuscular approach enhances the accuracy a lot. Dr. Weber, Clemens, thank you very much for showing us a little bit how we can do it. I've learned a lot, and I think I'm convinced to do this step with in our new hospital. So we are moving end of February. And I will show you my personal experience. I guess in 5 years, I think it needs some time, some training on cadavers, on real spine models, or whatever you put MIS. And for the pedicle screws, you make an extra incision. You can, yes, you can try a pseudo MIS approach for pedicle screws. This could be a way to gain experience. Clemens, thank you very much. It was extraordinary. It was mentioned in the chat box as well. And it's really, really great to have a surgeon who shows how to do it in this field that will develop a lot in the future.
Thank you very much. Thank you very much for the kind words and the invitation. It was very nice to be here.
And I'm inviting you when you're in the new hospital for sure. So next week, we will announce as usual on the social media channels, on X, on LinkedIn, what the topic. I guess Dr. Grosbach will present a guest, and I say goodbye to everybody. Thank you again, Dr. Weber. Thank you, Clemens. It was extraordinary. Thank you.